it might be that we get them to do just the movement as a motor control exercise, and that will give you mobility. So you're improving movement, not just motor function. But then you might progress that to holds where you're looking at endurance. Now, you don't have to do it in a supine position.
No.
You like the isometric ones?
Yeah.
We're providing the isometric, and which means the patient can do it anywhere, in the car, at traffic lights, you know.
And dose. Like, we don't just go, oh, just do these. Like, what would your prescription be? Is it 50%, you know, RPE of effort, or MVC effort, or 80? You know, what are we looking for? Endurance? Are we looking for strength? Like, and I think that's really important too. We're not just giving exercise for the sake of exercise. Give the patients clear guidelines of what we're trying to get. You know, you should be feeling this afterwards. You shouldn't be getting more headache after this or whatnot.
Yes, being really specific.
Yeah.
With the exercise, you can do true range resistance. Like you mentioned before, if they have neuromechanosensitivity, you can do it out of the provocative ranges.
And bring in, like, make sure when they're doing it with knees bent up or arms in or whatever, to reduce some of that neural load.
Yes.
Yeah.
Great, yeah. So you've got the flexors there, then you've got your extensors, and we showed you the example in 4.0 just now, but you can certainly do it off the edge of a bed.
And here we're looking at upper cervical extensors. So before we were looking at cervical extensors, because absolutely the head sits on top of the neck, so we need cervical extensors to be strong, but we also need to know how the suboccipitals are doing.
Absolutely.
And often I find that this can be quite hard because I don't understand there's two different ways. Like, there's upper cervical and then cervical. So you're teaching them that dissociation.
Yes, and that's the rotation as well, where you're dissociating. I mean, the upper cervical spine contributes to at least 50% of the full rotation. So just using the upper cervical spine rotation, they should be able to get at least, 45 degrees. And being able to use that 45 degrees well is very important.
In this position, I think it's also helpful sometimes for some patients to have a laser on top of their head. It can help give them some biofeedback, because instead of turning their head and following, you could even have a piece of paper in front of them with a line. They'll start doing arcs and they'll go up or down into flexion. So if that's necessary for the patient, that's not terribly hard to set up. And then what we've sort of run through with the upper cervical extension, flexion, rotation.
That's it. Using the right cues, the right feedback for the specific patient in front of you. Rotation
strength, actually we haven't spoken about that. Rotation and lateral flexion, I think, is also other parts. It's a sleeve, front, back. You've got muscles, sides, and we need them just as much. You will see ratios that, the extensors are stronger, than the flexors. But lateral flexion and rotation, I struggle to find exercises that load them well, but I find that, isometrics, unless you've got the machine, the isokinetic machines, like rotation against self-resistance, lateral flexion again, and get them to do it through ranges, like, do it in this position, and push as hard as you can. You can do it against pillows, but otherwise, like going into planking positions, if they can tolerate, like we're talking higher load, can they plank and hold their head up, lateral flexion?
Having a helmet or something on with a weight to increase load, some of those are strategies.
You can get fishing line with sinkers on either side, or we can have a look at some of this equipment that we'd probably have in clinic.
Yeah, so this is a fairly basic piece of equipment where you just have a head brace, and you can use, carabiners or something to hook a normal hand weight onto it, and that will add load for the extensors. And I think people forget that because the extensors are so strong, you really do need that external load to train them to the sufficient level.
And this is just a baseline. Like, there's no reason you can't get that patient lifting that head. And definitely sports would do it in the gym, like getting through and getting cables. The other thing is, in the meantime, if you don't have equipment like that, it's not hard to hook it up with a TheraBand.
That's it.
Yeah, but just make sure the weight doesn't bounce back and you go high enough. But you can hook it into TheraBand, like not tubes, but TheraBand, and sit the weight either side.
Something like a swim cap might be helpful with the hair sliding with the TheraBand.
And the hair.
Yeah.
So, progression of exercises being really important to the dose that's needed.